Okay, welcome to the Sean McGuinness podcast. Today I'm delighted to have on Dr. Emily Splichal. Is that right?
Absolutely.
No, thank God. It's the hardest bit of the podcast. So Dr. Emily, we'll get straight into it. First of all, just a little question I like to ask people when they come on. What kind of research have you had your head in lately, or is there anything particularly you fancy?
I'm all about the autonomic nervous system and stress. So how stress affects the body, how you can mitigate stress, how a lot of us don't even realize that we're stressed. So that's kind of where I'm vibing right now is stress.
Yeah. So obviously you started with the feet, and now I actually have this book here. I wanted to bring this up. This is like from the 1930s. This physio I'm mentioning at the moment told me to get a body mechanics, and in this they obviously talk about the dysfunctions. There's a whole chapter on the foot, and this is about 100 years ago. So obviously you've started at the foot, but to understand that and how it affects each other, you've kind of obviously branched out up the chain, and now you're going deeper obviously within the nervous system. Is that right?
Absolutely. So our feet are obviously our body's foundation. That book was probably referencing about, the arches and supination, pronation. I often will say that it's kind of like the foundation of a building or a home, that if that foundation is not stable, right, everything kind of collapses in. All of that is true. Now, the other side that I would actually add to it is that our foot is also a very powerful sensory structure. This is going to be the nerves in the bottom of the feet and how you can access them, or how things like shoes can block them. And then your foot is also a very powerful fascial structure. And that means that fascia, which is the connective tissue in the body, connects one muscle to another muscle to another muscle. And you can connect the tips of your toes to your tongue by fascial lines. So very powerful structure that we're talking about.
Yeah, it's so interesting. That's actually how I came across yourself. I went into like Depot, Dr. Daniel Lieberman and all those kind of fascial guys where they're talking about running, and then like evolutionary how the foot came about and how smart the foot is. And then when you look at kind of like, say for example, running, how people are running in the modern day, it's completely like goes against what the foot's made for in general. So I'm sure a lot of that frustrates you as well, thinking all that kind of stuff.
Yeah, unfortunately, there's a lot of things in modern society that go against kind of the evolution or the natural function. But I feel like more and more there's attention to, barefoot training, minimal shoes, strengthening the feet. A lot of people never used to think of it as, I train my biceps, so I need to also train my feet. So it's good to see that people are now more open to this as well.
So just obviously you started in the nervous system. Tell us how kind of the toes interact, and that's like probably our main sensory to the world around us, and then maybe how shoes and stuff are obviously doing that a disservice, and then the consequences of that as well.
Yes, you can think of the nerves in the bottom of the feet and the skin in the bottom of the feet as kind of like our eyes, in a sense that they're constantly reading the ground in every step that we take. And I often will say that not two steps are exactly the same, which means maybe the surface that you're on, the terrain, how hard you're striking the ground, the acceleration of your foot and the limb. So lots of sensory stimulation that comes from each step that we take. Now, our ability to feel that sensory stimulation controls the movement pattern, and we want to be accurate, right? We want as much information as possible, and we want accurate information coming into our system so we move better. Shoes, especially shoes with cushion in them, can actually block that sensory stimulation from coming in, which means that you don't get all the information, or you might get inaccurate information. And then the movement pattern is a little bit slower, a little bit altered. You see it primarily in high level performing athletes, and then also in people who have neurological injury. So those are where you're seeing kind of the biggest impact of things like cushion or perception of the feet, where some of the listeners who are young and healthy and, you know, might not have any injuries might say, well, I don't notice a big difference if I go barefoot or not. I often see the biggest like kind of snap effect in those that are really looking for these subtle changes, like I was saying, high performing athletes or people who have had a neurological injury. Doesn't mean that just because you're young and healthy, you should not pay attention to your feet, because they are impacting your movement. You might not just feel it.
Yeah, it's kind of like, well, something has to take that impact up the chain, and that will obviously show itself down the line. When looking at like running shoes, especially with a lot of cushion, is it right in saying that because your foot can't feel the ground, the impact is going to be higher because your foot's always trying to get in contact with the ground to see where you're at space?
Yeah, so when you look at force curves, so they'll actually look at how much impact is coming in through certain strike patterns, heel versus midfoot, or shod versus barefoot, or cushion versus minimal shoes. So it'll look at all of that. And oftentimes what they see is that people will strike harder when they have more cushion in their shoes because of what you had said, that they don't feel it necessarily. So they need some sort of stimulation. So they have to hit harder to actually feel that stimulation coming in. So that's a really important part. Other thing that I do want to mention that is important for the listeners is that cushion in shoes makes us also a little bit slower. So you're on the ground a little bit longer than you should be. And everything that has to deal with movement and injuries and performance has to do with our goal of getting off of the ground. You never want to be on the ground. Even though we stand on the ground and we walk on the ground, you want to kind of quickly get off of the ground as efficiently as you can. And the longer that takes, you're just exposed to these impact forces at a higher level. So those are kind of some additional ways you can think about it.
Yeah, that's obviously when I played sports all my life, and then coming back to, let's say, sprinting, where, like, as you said, the idea is to create as least contact with the ground as possible so you can keep going, or running in general. And I've tried barefoot running, and there's some actually publishers, I think of like the Vivo Barefoot, where they measured some sprinters and they actually ran faster like without their shoes, simply because you're less contact with the ground. So what, for that transition, how do you like progress people through the stages of, okay, the really poor foot mechanics, they might have orthotics, all the way up, because you don't want to jump because you're obviously, those muscles are not conditioned to do that. So what's your kind of progression itself?
Yes. So I always look at it as a balance of strength and recovery. So part of getting out of, let's say, orthotics and structured shoes and supportive footwear, and then to transitional to, let's say, eventually minimal shoes or barefoot, is that requires an element of foot strength. Just to get into barefoot shoes or minimal shoes shouldn't be the exercise. This is kind of like runners who run to run better. You also need to do cross training, right? You need to do other things to make you a better runner or a better athlete, right? So to look at the foot before you even start to reduce the support and the structure and start to strengthen it there. Do foot activation, foot releasing, short foot exercise, foot to core. So anything that's going to start to strengthen these muscles in the feet. Doing balance exercises is one of the best ways to strengthen feet as well, feet, core, hips. So if you do that, you know, several times a week for, let's say, 4 weeks is generally what I would have patients do, or individuals, but you stay in your orthotics and your structured shoes when you're not training, right? So that's your environment. Then after doing that for 4 weeks, okay, we got some baseline foot strength and foot awareness. Let's start by taking out the orthotics, but stay in the structured shoe, right? Do that for a while, okay? And then start to go from a traditional supportive shoe to a transitional shoe. And a transitional shoe typically won't have a counter. So a counter, fortunately, I don't have a shoe with me, is the back of the shoe. It's stiff, or it'll not have a midsole. So you can kind of twist the shoe a little bit. You'll have a little less cushion. So it's intended to be this middle shoe. It's not totally minimal, not totally structured, smack in the middle. That's a great way to transition out of that structured shoe, be there for a period, right, while you're still strengthening your foot, and then eventually get into the minimal environment. Now, while you are doing that, the recovery over here is extremely important. You want to make sure that you're releasing your feet every day. 5 minutes in the morning, 5 minutes in the evening. You're releasing your extrinsic muscles, so your calves, your perineals, the front of your shin. You release those muscles because they have to work harder in more minimal environments than over here in the structured shoe. So they require daily consistent recovery, even in people that do it all the time. If you run minimal and you're always barefoot, you still got to recover your feet over here. You can't offset this. And that's how I typically take individuals through from a totally structured custom orthotic structured shoe all the way to minimal or barefoot.
Yeah, I think that's brilliantly explained. Going on, I don't know how you explain this. Do you have a particular way you'd like to see the foot, like optimally? So how you line up from the big toe, obviously, like to your talus joint or your heel. Do you have certain things you look for in a good postured foot?
Yes. So when I look at a strong foundation posturally, this is technically called a plantigrade foot. So a strong foot is a plantigrade foot, and you want to be on your foot tripod. So the foot tripod would be under the first metatarsal head, the fifth metatarsal head, and then the heel, right? And then once you're on the tripod, you want to lift your digits and then spread them out nice and wide, and then place them back down on the ground. And you're looking for what's called toe purchase. So you want all of your 5 digits to be long, straight, flat, and in contact with the ground. That's ideal there. And then from the rear foot or the heel, if you're pronating or dropping down, I need you to lift or rotate your tibia, so your leg bone out, and then that will lift the arch and put it into a neutral position. So I need the rear foot neutral, but it comes from a rotation of the tibia, foot tripod, digits, long, straight, and flat. And then that would be this ideal plantigrade foot with even body weight distribution. So then you could essentially take it and say, you know, do you have even body weight between the left and the right, the front of the foot and the heel, right? So you're kind of finding center as well from a body weight perspective.
Yeah, that's brilliant, because I think a lot of people, again, when they try to do tripod, they'll end up just like gripping the ground with their toes, and obviously that's a sign of instability anyway if they're trying to just get that extra support. I obviously have so many questions on this because you're the first podiatrist we have on. For people that say, or how do you tell the difference between someone that has, let's say, pronate foot or like fallen arch or whatever, structurally versus like man-made? Or is there difference in like different cultures and different people?
Yes. So there are two types of flat feet that I'll talk about. And there's several, but I'll just talk about 2 where flat foot really is not a term that I use, even though I'll use it on shows like this or interviews, but it's really pronation. So the pronation is a rotational element. Your arch doesn't just kind of drop flat like that. It normally spills and rotates into the midline. And that's based off of how mechanically things are interconnected or coupled. So the coupling is how you connect your feet all the way to your hips and your pelvis, let's say. So when you rotate in like that, that's a type of pronation, overpronation. It could be flexible or it could be rigid. So flexible would mean that if I sit here, open chain, and I just put my feet out and I show you my feet and I have this beautiful arch, and then I stand up and my foot goes boom, right? It's flexible because I have the potential to make an arch. When I don't have gravity and body weight on me, I have a beautiful arch. As soon as I stand up, right, I drop down. So that's flexible. The other one would be more rigid. And oftentimes the rigid flat foot or overpronated foot is a progression of the flexible flat foot. And I might have to actually go into a third foot type, which I will. So a rigid overpronated foot that is a progression of a flexible overpronated foot is one that if I sit here in my chair and I put my feet out again, you can see from across the room that I have a flat foot, right? It just like, you can see that I'm bearing weight on my entire bottom of my foot, which is not how we actually bear weight. You typically have darker skin on the weight-bearing skin. If someone has darker skin on the inside, that's more like a rigid overpronated. Those are two really common ones. One's a progression of the other one. The third one, which I'm going to have to go into, is a pancake foot. I consider this a type, and just loosely saying pancake. That actually is one that it is more like I don't have an arch and it's just like this. There's no rotational component to it, but people are born with this. So this is not structural because of weakness. It is genetically how my bones shaped because of, you know, how I was born and, you know, things like that. So you typically will see pancake feet in certain populations. And I've been blessed to travel all around the world teaching, and I've seen all different types of feet in different countries and continents and stuff like that. So depending on where you are, the oldest population, so a lot of Asian cultures have pancake feet. And then also when I go to Africa, they have a lot of pancake feet, and it's part of their genetics on how the bones shape. That's a third type of foot that you'll often see from flat feet.
Yeah, the genetics of especially so interesting. I think over here, because obviously rugby is such a big sport, and Polynesian, all on their cultures, I've heard, again, that's like a genetic thing. And then that relates to, like, I think they have higher rates of like ACL injuries because naturally they have a bit more valgus in the knees and stuff. But for the other two, there's no excuse. Is it a case that the longer that structure's been there, then it becomes more rigid, there's more structural changes over time?
Yes, if you think of this flexible overpronated progressing to a rigid overpronated, what is making it progress to rigid is the arthritis. So wearing down the joints. So as soon as I collapse down, almost like if you stand in a knee valgus and your knees are knocked or you're falling in like that, you lose proper joint alignment, which means the cartilage is not aligned anymore. You wear down cartilage, you get inflammation, you start to get pain, and then you lose the joint range of motion. That's kind of how it progresses, is that you get a lot of arthritis and spurring in the rigid flat foot because of that flexibility that's happened.
Yeah, even more so, I think, if you have that flexible to do something about it. So what would be kind of your go-tos for like an overpronation? And then do you differentiate between if there's more like bone spurs and the flexible versus the inflexible foot?
Yeah, so I always, if I get a patient that has flexible flat feet, flexible overpronated feet for collapsing in, I then grade it on a mild, moderate, severe. And that would just be a little bit subjective based off of experience. So kind of going through those. Now, if you're mild to moderate here, my first line of defense is going to be exercising, strengthening the feet, doing short foot, intrinsic muscle strengthening, core strengthening, glute strengthening, everything that we know that is beneficial here. If it is a little bit more severe, which is typically associated with ligament laxity, so there's another genetic contributor, structural contributor to that type of foot, they may need orthotics. And I don't want any of your listeners to like hang up now because I said orthotics, but there are certain hypermobile, ligament lax feet that requires something to hold them in place, especially let's say if they were playing rugby or something like that, something with high force and speed going through them. They might just be blowing through their connective tissue and they cannot control it. And there's no way for muscles to override ligament laxity of tissue. It's extremely difficult in the foot. But if I do give someone orthotics because they have moderate to severe overpronation and ligament laxity, they're still doing the exercises over here. It's not just one or the other. They're often combined in many cases.
And before everyone thinks that's what they have because they have orthotics, or what percentage of people are like, how kind of rare is the ligament laxative?
I would say a majority of people are more on the could benefit just from exercise and don't have to be in orthotics. The podiatric community probably wants you to think everyone's over here and needs orthotics, but I have spent a great deal of my podiatry career getting people out of orthotics. So, you know, majority of my day is having a conversation of strengthening the foot and getting out of orthotics and wearing minimal shoes versus prescribing orthotics. So I actually do very few orthotics, but I know when it's appropriate, and I do still encounter those patients.
Yeah, it's like anything. There's always outliers, isn't it? It's the same with like
Yes.
medicines, or in some cases genetically that person may need that, but a lot of times you can just prevent it with preventive medicine as well. Going on pronation, or collapsed feet, for people that don't know, obviously then they've made shoes to do the opposite of that now, and prevent people from pronating at all. And then people, well, especially I don't know, in the fitness field, then a lot of the time everyone was very scared of any pronation, and then where it was actually having opposite effects. So when people were squatting, they were driving the knees right out, but then the weight was more on the outside of the foot. Like, what problems does that have when you're not walking and pronating properly in the gym or outside of it?
Yeah. So if on the other side of the spectrum would be supination, would be on the other side, right? Or inversion, your body weight is shifted to the outside of the foot or the heel. So that higher arches is where you could say that that foot type is. That causes a similar rotation up the leg, but it's going to be opposite. So now it's actually rotating you out, where pronation rotates you in, it knocks your knees, is pronation, flat feet. Supination or higher arches typically is rotating you out. So that can put a lot of stress to the outside of the ankle, outside of your knee, your IT band, all the way into the hip. So typically, so that's referred to as your lateral line. So lateral line tightness can be very much associated with that foot position or that foot type. Other thing that that foot type typically is associated with is rigidity. So stiffness, so stiff feet, stiff ankles. I often say that if someone has stiff ankles, they have tight hips. So they will often have tightness all the way up in the hips. If your hips are tight in your pelvis, now your lower back is tight. And then maybe their T-spine is. So it goes all the way up. And if you're trying to connect or see how this really could connect, could be like a shoulder issue in someone with higher arches and more of a supinated foot because of rigid feet, rigid ankles, rigid pelvis. Now the T-spine can't move. And if your rib cage doesn't move, you're cheating out of your shoulder. So all of this stuff is connected. But yeah, that's where you would want to go more on the other side and say that foot type has to mobilize your feet, mobilize your ankles, your pelvis, your rib cage, all of that needs to open up.
Yeah, I'm just thinking of my dad at the moment. He had an injury a while ago, and then we're working on his legs, strengthening his legs. And then one day I was like, actually take your foot off. And his foot was just like a claw, like he's walking on the outside, no pronation. And it's taken us a while. I obviously got him in like 5-finger shoes, just trying to get some pronation, because obviously then the normal running shoes are actually doing him even worse. His mechanics are even worse. But it's really cool the way obviously you're referring to up and down the chain, how everything affects each other from the foot to the hip to the ankle. And then also from a fascial point of view, looking then across the body in the back. How long did it take to kind of go into that, or in your career, how early on did you discover moving outwards from the foot?
Yeah, so I've been in the fitness industry for over 20 years. I finished podiatry school about 10 years ago, just to give perspective on things. And it wasn't until I finished, actually for residency, so residency licensed for 10 years. So it wasn't until I was licensed that I started exploring these other things. I got into the Barefoot when I was still in residency training. And then I knew that there was so much more to the foot besides just the skin. Like I was just thinking like, okay, the skin, I can feel the ground. I didn't connect it to the brain yet. So I was like, oh, okay, it activates the brain. And then I got into breath. So natural progression became the pelvic floor and the breath and the way that people breathe. And then that evolved into the fascial lines and the deep front line and foot to core sequencing. And now I take it even further and really look at the autonomic nervous system, which was the stress that I was talking about. So the way that our emotions can influence our movement just based off of, these subconscious responses to the nervous system and inflammation and things like that.
For people, I'm just trying to think, how do you differentiate then, say for example, someone comes in with like feet massively turned out, okay, and then sometimes that could be caused by obviously numerous things, but say like a big anterior pelvic tilt could cause them to rotate their feet out. How do you work together with people, or do you kind of give them the exercise themselves to fix both? Because obviously then, if am I right in saying, if you just fix the foot, because that's a compensation, it could actually cause them more issues if you don't fix it from the hips and pelvis.
Yeah, all of my programming always involves feet and pelvis.
Yeah.
So I actually don't ever give just foot-based exercises or rehab techniques or mobilizations. I'm always addressing really feet, ankle, they go together, pelvis, and then T-spine. So most people, whether that's a mobilization technique, it's a pelvic floor activation, it's diaphragmatic breathing. And this could be for someone with chronic plantar fasciitis, is that I need them to get into their pelvis mobility or into their diaphragm and stuff like that. And then that's where I'll also look at, okay, do you even feel your feet? Do you need to bring in sensory stimulation every day? Oh, are you stressed out and you actually don't feel your body because of your level of stress? Okay, well, now we're doing diaphragmatic breathing more to control your autonomic nervous system than to get into your pelvic floor. So it kind of depends, but yes, every patient is getting a upper pelvis adjustment as well as feet. And I determine a lot of that based off of movement assessments. And I also think that's really important for the listeners is if you're a patient or a consumer or a client, the words you use to the doctor, coach, therapist actually tells more, in my opinion, than the assessment. So if I just listen to you and ask the right questions, that is actually more powerful than watching them move, because the body is so complex that your movement pattern, like you were saying, the feet turned out, we could have like a little powwow and just keep listing everything that could possibly cause that. And it's hard to just say, oh, it's that, and that's what caused you to turn your feet out. Because some of it's also a chicken or egg thing, like kind of what came first, because you walking with your feet turned out tightens your ankles, but tight ankles causes people to turn their feet out. So which is it, right? So that's why I like to really ask questions, and I can get a lot of information from that.
Yeah, amazing. Like constantly like zoom in, zoom out model, and then obviously see the body as the one system, everything that affects each other. It's kind of like one of the physios I mentioned where it says the same thing.
it's such a like vicious cycle in one way or the other. And obviously if someone's then stressed and then whatever that's affecting the nervous system, that's going to limit your ability to actually structurally change them because they're in that sympathetic mode too much, right?
Yeah, yeah, and even for an example, for if any of the listeners have like, I don't know, I'll use plantar fasciitis as an example. One day you're fine, you have a flare up the next day. It could have been something you ate, honestly. And then you don't even know that you have this inflammatory reaction to a food or an ingredient that you had, and then that caused that flare up. So that's how complex the body is.
It's gone full Paul check on
Uh, you're welcome. I don't know.
No, that's good.
But it's true. It's true.
I think it's coming back. That's
It's-
actually coming back more popular now. Everyone's like realizing, oh, actually, he's talking with a lot of sense back then. But then
Yeah.
you could go further, right? Because you could probably say, from a psychological point of view, someone's personality shows up in how they move, and then that over time becomes their structure.
100%.
Yeah, it's pretty interesting. Going back to my interest in sports, which will probably interest a lot of people, sprained ankles. Like I've sprained my ankles so many times, and look at what I know now. I'm like, oh, I wish I knew this back then. I just used to strap my ankles up. Combination with that, I used to think the tighter the boots, the better. So I'd probably wear 3 pairs of socks in the tightest shoes, thinking like, oh yeah, I feel faster. What impact does that have? Like, you can break it down. First of all, sprained ankles. You probably get people in and ask them, okay, what's your injury history? And then over time, they say, no, nothing. And then you're like, oh, what did you do to that foot? Oh, I've sprained it 20 times, but I don't think anything of that. How does that affect like us mechanically, first of all?
Yeah, so I just did something with the NBA here in the US, so the basketball, and just to give you some perspective of stats that I had used is that every season 25% of basketball players, NBA players, will sprain their ankle, and then 70% of ankle sprains, whether it's the 25% of NBA players or 25% of the listeners to this podcast, 70% of those people are going to experience recurrent ankle sprains. Their ankle is going to just give way spontaneously, or they're going to be diagnosed with chronic ankle instability. So ankle sprains is a huge, huge issue in professional sports or sports in general in the healthcare system because of the recurrent nature, the chronicity of this injury. Now, what I'll often tell patients that experience this is that there's 2 ways that we stabilize our ankle. You do it mechanically and neurologically, proprioceptively, but neurologically. The mechanical, that's the actual ligaments, the ligament that will only let you stretch so far, right? Like I can only move my arm so back before I tear tissue, right? So tissue, ligaments, tendons, capsule are mechanical stabilizers of joints, and they limit your range of motion. If you tear it, you've lost your mechanical stability because you tore it, right? You tore the ligament. Over here, so that's mechanical. Over here, you have the neurological, that's the perception of your joint moving. It's called joint position sense, what activates the muscles to stabilize, right? When you look at what is more powerful or more controlling of foot stability, it's actually mechanical. So if you tear or you lose the mechanical, the neurological tries as hard as it can to make up for that loss, but it can't. And that's where you start to get into these recurrent issues. So the best strategy for preventing recurrent ankle sprains is to prevent the first one that ever happens because of that. And I've actually worked on some medical boards that were focused on high school athletes. And we're saying that that's where the injury is happening. If you get a high school athlete that gets an ankle sprain, they become a collegiate athlete, an adult, a professional athlete, anyone, don't care what your age is outside of high school. Now you have recurrent ankle sprains and ankle instability. So when we think of that, that's really important. Athletes such as what you were doing is you were trying to replace the mechanical. right? So if you have mechanical here, people will say, put a brace on, that's mechanical. Tape it, that's mechanical. Wear high top shoes, that's mechanical, right? So you're trying to mechanically block the ankle from moving. What happens though is that if you take away that range of motion, it has to go somewhere. And it typically goes into the knees, higher up the chain. So I'm not a big fan of mechanical restrictions of ankle mobility to try to make up for the fact that there was an injury history. I try to stay on the side of neurological as much as I can. And that's where like our Naboso products come in. Rock tape or kinesiology tape is oftentimes used. So other strategies like that.
So then once you kind of tear those like mechanical receptors that are involved in stability, can you build it back up through the proprioception drills that you talked about earlier, or is that done? You just have to try to stabilize everything else.
Yeah, so you then have to try as much as you can through proprioceptive neurological to make up for that difference. You'll never take the place of the ligament. You could do surgery and you could surgically fix the torn ligament to bring mechanical stability back to the ankle. But even at that, a lot of people that have the surgery for torn ankle ligaments have issues after it also. And I just think it's the nature of the freedom of movement of the ankle. You could almost say like the amount of stress and freedom of movement of some of our vertebra, and how herniated discs are just, you know, another very common issue that people have to deal with in certain sports or certain movement patterns. The ankle is almost very similar over here, like, ankle sprains. And I'm like, herniated discs. They're kind of similar in how the body moves.
Yeah, and then we can obviously think of even like, as you said, how generally you can go from a back injury to originate in a foot. Then you like see people in and go and getting their back cracked. You're like, oh my days, like so much more to it than that. But that's the nature. And the second thing with that, for the people like me used to wear the tight boots, or listeners that may have a nice pair of Louboutins, what do you like tight shoes, and what are their effects, first of all, maybe on performance, but overall mechanics, and then what's the repercussions of that?
Yeah, so not natural shaped shoes, not foot shaped shoes, meaning, you know, your beautiful, you know, Louboutins or whatever, you know, people are going to wear, you know, this kind of that narrowed dress shoe, or a cleat, or it could be a cleat as well, right? Like a soccer cleat or rugby and things like that. That narrowed position is preventing foot splay. So a really important part of how our foot stabilizes is that as it shifts forward, like we're about to take a step, so you're shifting forward to the front of your foot. As your body weight shifts forward, there's this reaction of the foot to spread and widen. And what that does is that dissipates or evens out weight pressure distribution and weight distribution, but it also is pulling on connective tissue or fascia, which is nervous tissue, nerves, right? That triggers stability in the foot. So splay is very important to natural foot function and to optimizing foot stabilization, and force output is based off of the foot being able to spread or splay. Now, a lot of narrow shoes that are also stiffer materials, like a stiff leather or something like that, and it doesn't allow the foot to spread at all, it blocks that splay mechanism. So the foot becomes less stable. It can lead to neuromas also, lead to hammer toes, bunions, so like forefoot issues. But I always look at it more from like a stability perspective, and it's actually interfering with the stabilization sequence that needs to happen during dynamic movement.
And what's your advice then for women that, I don't know, maybe have to wear those kind of shoes? Can you even it out doing something else?
Yeah, so what you do when you get out of those shoes is extremely important. So a dress shoe, a high heel, a cleat, it's a reality. People have to be in them, choose to be in them. That's their own decision, right? Or it's requirement of a certain sport. So when you're in it, you're in it. When you're out of it, what can you do to release or reverse the stress that was placed on the foot? Release the bottom of the foot, roll and stretch the back of the leg, the calves, the perineals on the outside, and then open up the digits with something like, these are little toe spacers, something that's going to kind of create some sort of spread into the digits so that you can create that more natural foot alignment. Yeah, as optimally as you can. If people are curious of a fun fact, that the splay or the spread that a female needs functionally is about 3 millimeters, men is about 5 millimeters. So it's not a lot, but in the foot, if you start compressed, you're already compressed. You can't go anywhere. So you don't want your shoe to be actually tight against the forefoot because you're already at your end range of motion, if that makes sense.
And like you said, when that leads to bunions and stuff, is there a point where there's no going back and it's about management, or is that bunion like more of a bone spur that's just going to stay? Like, how do you view that and how that progresses?
Yes, so bunions is another highly controversial topic, but bunions are structural. And I often say that you can push pause on bunions. So that's what I would like the listeners to think versus I'm going to cure myself or reverse this bunion, especially when they go on the same scale as my flat feet scales, mild, moderate, severe. Those that are on the side of moderate to severe, your goal is to really try to keep a centered joint. I recommend the toe spacers for anyone with a bunion, to keep a centered joint, to stabilize the foot, and then to push pause on the progression of that bunion.
Yeah, that's great advice. Okay, last question, because I'm asking too much. This is just interesting for me. When you deal with a client, you come in, and obviously from a physical point of view, from a physiological point of view, how do you then rework that into overall gait or how that person's moves? Or what are your cues for maybe walking effectively?
Okay, that is a really good question in the sense that I get a lot of patients that have gait imbalances, even if it's just a compensation and their SI joint bothers them every time they walk, or their heel or something like that. Walking is a subconscious movement pattern. So if you you can't slow down the way that you walk. You just can't. You can't consciously walk. It's not the way that walking works, right? So I like to optimize the range of motion and the integrated range of motions that are required to walk. Meaning if your leg is behind you and your toe is flexed, right? You're about to take a step, right? And you have this reciprocal arm and your T-spine is rotating. Can I just make sure statically that you could stretch and open your body in that position, and then obviously do the other one? Do you have the stability on a single leg stance? Do you have, quick glute activation? Do you have strong feet? Do you have strong digits or toe, right? So I try to make sure that the elements in their individual nature, that the range of motion is there, the sensory stimulation is there, the strength is there, but to put it together, you just got to walk. I can't slow it down. I've had patients actually show me how they walk slowly, and I'm like, why do you you can't do that? You don't get anywhere. You can't walk that. I believe in Feldenkrais, which is a method of really slowing down and conscious walking and stuff like that. But you're not going to make any subconscious changes by walking slow like that. So it's a hard thing to deal with. I would actually rather put someone on like an Alter G treadmill and take off the weight and the impact and just do the mechanical movement pattern, or to do it in water so that they get the reciprocal movement. And walking is a reflex within your spinal cord. So if you bring in the appropriate sensory stimulation and the range of motion, it's something that's almost pre-programmed in your nervous system that you should be able to achieve it based off of checklist mobility, checklist sensory stimulation, and then check local muscle strength. But that's just kind of my take on that.
Yeah, no, 100%. So just give your body what it needs, and then it will kind of self-organize itself then after. From a foot point of view, like for optimal gait, so what is there certain things you're looking for, like a certain level of dorsiflexion or a certain level of stability, obviously tied in with kind of quote unquote fixing maybe those imbalances first?
Yeah, so if you're thinking of someone taking a stride, and it's hard on Zoom because you really can't see my whole body regardless of what I do, but if you just stand up and pretend to take a step, right, your back leg, your toes are flexed. So you need to have at least 30 degrees of flexion in your big toe, specifically all of them, but your big toe for you to walk. Your ankle, you need 50 degrees, 50 degrees of plantar flexion in your ankle to push off the right way. When you're loading in late mid stance, you need at least 10 degrees of dorsiflexion. So there's certain range of motion that you need in joints. Yes. And then it's really kind of the timing of each of those range of motions, right, as well. And that's why I keep beating a dead horse, but the sensory is really important because it's the rate at which you achieve these patterns that's actually more important than me just saying like, oh, okay, can you flex your joint? Or, oh, can you activate your glutes on the table? I don't care about that. I want to see their glute and the timing when they're actually walking, and that's now easier to do with, EMGs and some of these high-tech sensors that are out there, but it gives you the true perception of what's happening and the complexity of what's happening as well.
Yeah, no, I think that's brilliant. For, just as you mentioned, the big toe, for people that may have like a rigid big toe or that don't have that degrees of flexion, what hope do they have, or what compensations do they make to move then if they can't really push off, or what can they do as well?
So if you cannot get through a joint, I don't care what joint it is, if you can't get through it, your body is going to go around it. So one of the most common compensations for someone that does not have range of motion in their big toe, which is required to take a long step, you need to have flexion in your big toe. If you don't, you're not going to take a big step. You're going to shorten your steps and you're going to go around your big toe, which means you turned your feet out. So that is actually one of the drivers to your example of someone walking like a duck with their feet turned out. My mind would say, check the first MPJ or the great toe, because if they have a rigidity or insufficient range of motion, boom, that's driving the compensation. And then that compensation is leading to many other compensations, right? So what I like to do with those patients or individuals is you can actually use a 4-foot rocker in it. So your shoe, you can have a slight rocker. Hoka, as an example, is a rocker-based shoe, and you can rock through the shoe versus through your foot. Some people will argue that this is not natural and that it's weakening the foot. But if someone can't move through their big toe, you have to pick your evils. Like, which one do you want, right? Do I want the rocker shoe or do I want them to compensate by turning their feet out? I would take the rocker shoe.
Yeah, that's interesting. As you said, there's like kind of a tool for each person to do that. Mm-hmm. How do you walk around seeing people running? Like, can you turn your brain off when you're seeing all these people with funky feet turned out and techniques? How do you ignore that? because we're in lockdown over here, and I live right beside one of the biggest parks, and I see everyone strapped up in knee straps, and oh my days.
Yeah, it's definitely hard. I lived in New York City for 20 years,
Oh, yeah.
and that was very good case studies. I would just watch people move, but I love people watching posture, movement, body awareness, lack of body awareness.
Yeah, I
Most
think I'm at the
people
stage
have a
where,
lack of body awareness.
like, obviously when you develop like that coaching I went, then you start to notice it more. At the start, you're like, I know that's not right, but I don't know why. But then obviously as you get into it, you're more like, okay, yes, that can be
Yeah.
a little case studies. Dr. Emily, that's absolute gold. I love everything you put out. Where can all the listeners go and find you? Because I definitely recommend they go and check out all your stuff. It's brilliant.
Yeah, thank you. Thank you so much. So I am on Instagram, which is Dr. Emily DPM. That's my Instagram. I do education on there. I try to put as much education as I can out. So content to empower both the consumer, the patient, the client, also the trainer and the coach. And then I also have my education company, which links to my YouTube with many more videos on there. And that is ebfaglobal.com.
Yes, go check that out. Thank you again, Dr. Emily, for coming on. I really appreciate it. Great chat. And I'll definitely talk to you soon.
Thank you so much.